Yes, good evening, one and all present here. The Department of Psychiatry, D.Y. Patil School of Medicine, Navi Mumbai, has always attempted to pursue academic excellence. In that vein, we started a PG lecture series for postgraduate students of psychiatry from all over Mumbai and its periphery in 2015 under the leadership of Dr. Rashmi Chalras. We have other intention to do it for now. Even the PG psychiatry video lecture series as an extension of it. This lecture series helps expose PGs from all parts of India to variety of experts in the respective subjects, well their backyards from all across the world. We hope this helps PGs and psychiatrists alike from all across the country. We continue to strive to make further advances in our teaching endeavors. The lectures are available on the website pgpsychlectureseries.com. And this is an exercise we have been doing every month on first Thursday with the subject experts for all the psychiatrists and the PGs. Students have and the psychiatrists have really enjoyed this lecture series. Next slide, tech team. Warmly welcome Dr. Shobit Garg, Professor of Psychiatry from Dehradun, on the topic Tics and Tourette. For and the moderator for today's session is Dr. Pawan Kumar Kulkarni sir. He's Professor Head Psychiatry, CIMS Karimnagar. Next slides, please. It's pleasure to have you, sir, Dr. Pawan Kumar Kulkarni, sir, as a moderator for today's, as a chairperson and moderator for today's session. Sir is Professor and Head Psychiatry, CAIMS Karimnagar. He has had various Indian Psychiatric Society leadership role as an Assistant Honorary Treasurer between 2024 to 26, Honorary Secretary uh, in IPS TSB 2021 to 23, EC member for IPS TSB 2 terms. He has been a part of various committees and convenerships, convener of SS Private Psychiatry, convener of SS Positive Psychiatry, member of IPS South Zone Publication Committee, member IPS Newsletter Editorial Team, member Scientific Committee ANSIPS 2025, Organizing Secretary IPS TSB Midterm CME 2018-19. I hand over the proceedings to Dr. Pawan Kumar Kulkarni sir for the further proceedings. Thank you.
Uh, Thank you, and at the outset, I thank Dr. Ashwin sir and Department of Psychiatry, D.Y. Patil School of Medicine, PG Psychiatry Knowledge Series. And it is a well-known program across all the postgraduates, and I'm happy that to be part of it. Today's speaker, Dr. Shobit Garg sir, is a well-known uh, psychiatrist across the psychiatrist forums. Many of the psychiatrists know him, but for the postgraduates who are new, Dr. Shobit Garg sir is currently professor in Department of Psychiatry at SGRRIM at Dehradun. He is the president of Himalayan Psychiatric Society. He also worked as honorary secretary and EC member of IAPP, UP and UK. He was a co-chair in Neuropsychiatric Committee, IPS. He is associate editor, Archives of Biological Psychiatry, and is chairman, research review and in charge neuromodulation, SGRI and HS, and is a past convener neuromodulation IPS. And his research interests are bipolar disorders, brain stimulation, and he has around 115 publications credited, and he has written 18 chapters in various books. Today's topic is also a very interesting and novel one, like tics and Tourette's. Most of these are quite often these symptoms are missed. They are not diagnosed at all till late. So without much waiting, I'll hand over the session to Dr. Shobit sir. Sir, please take over, sir.
Thank you, sir. Thank you for the kind words. I think it is my second face-to-face with the very esteemed, a platform, and which is doing the most novel work is addressing the postgraduates, the future of psychiatry. I think at the outset, what we have planned is that we will do a 5 question survey today. I think, Dhruv, can you start the survey just to set the agenda and just to know how much we are comfortable with Tics and Tourette? And then we'll go to the presentation. It'll take a couple of minutes only. Dhruv, can you just start the
Yes,
survey?
yes, sir.
So we are doing this survey in Mentimeter. So there'll be QR code reflected and everyone can where is a QR code, Dhruv?
Sir, I'm good.
Yeah. So everyone can scan the QR code in their mobile and you will have this Mentimeter open in your handsets. I can see 3 have joined. I think we have around 30 odd audience. So we expect everyone to join the survey. Good evening, Rashman sir.
Good evening. I'm sorry, there was a bit of a technical glitch, so I couldn't join instantaneously, but I was in the background.
Right, sir. I think 12 residents have joined. I request everyone in the audience to join the survey. Would like to have everyone's opinion. Dhruv, can we go to the first question?
Yes. So coming to the first question, we will begin with fundamental question of the diagnosis of Tourette syndrome. So let's see how well we all remember the DSM-5 criteria for the same.
Dhruv, go back to the question. The question was not, I think, visible. Go back to the question. We couldn't see the question properly.
So this is
Okay.
is it visible, sir? Now?
It is visible. It is visible. I think, Dhruv, can we go to the answers?
Yes, sir.
So duration, the maximum response was duration more than 1 year. Then there is a tie between onset before 18 years, both vocal and motor tics, and not due to substance or medical condition. I think we'll come to this later on. Yes. Next question. Which pharmacological options are recognized for its tic suppression in Tourette syndrome? You can go for multiple options here. Clonidine, haloperidol, aripiprazole, valbenazine, fluoxetine. Okay. I think Dhruv put the answers. So clonidine, maximum, aripiprazole, valbenazine, haloperidol, and fluoxetine. No one has answered. We'll come to this subsequently. Next question. Have you ever applied or supervised CBIT or habit reversal therapy in Tourette syndrome? I think one question is send the link of survey here. There is a QR code. You can scan that and directly you can participate in the survey. This is kind of an a qualitative question. I just want to know that how much audience has been exposed to the treatment, or like in rounds anyone has got across the treatment. Interestingly, 50% of the audience is taking part in the survey. Dhruv, please go to the answers. So most of them are aware of it, but we have not directly basically applied it, or maybe we are not directly trained in it. Next question. How confident are you in differentiating tics from other hyperkinetic movement disorders in clinical practice? Ideally, this should be the first question, I suppose. And most major part of my presentation, I've actually tried to focus in this area. So are we very confident or are we not confident at all? We are still confused by the phenomenology of movements, what exactly they mean by it. Okay, I think Dhruv. So not confident. So it is skewing towards not confident at all. Okay, next. Rank these Tourette syndrome comorbidities by the frequency of their co-occurrence. Last question, I suppose.
Yes.
Yes. OCD, ADHD, depression, learning disabilities, specific learning disorders, or anxiety disorders. I think we'll have 10 responses and then we'll display the few more seconds. Okay. So ADHD followed by OCD, followed by anxiety, followed by learning disabilities, followed by depression. I think more or less it is correct. So I think audience is pretty well informed, I suppose, but the challenges are in practical hands-on and probably differentiating the disorders in movement disorders phenomenology or hyperkinetic movement disorders. Okay, Dhruv, thank you.
Thank you.
Can
Welcome.
you share your screen? Yes. So I'll directly go to the presentation. Yes. So first of all, my regards to Rashmin sir. I think after last presentation, I suggested him that why not let us discuss tics and Tourette, which is not routine, which is generally considered that it is taken up, that we all would be knowing about it. Somehow we will have good concepts about this, but without explicitly being taught, it becomes a little difficult. So I think this is an interesting area. So with this, I do not have any financial disclosures of conflict of interest. I'll not be discussing neurobiology in this presentation. I think everything is heavily laden in your textbooks, CSTC circuits, and other models. You can go and access those. Few videos have been shared with patients' consent or their nominated representatives' consent, and a few videos have been taken from neurology sources like Continuum Neurology. It's a very reputed source. I'll share you the reference also. And my acknowledgement to Dr. Abhishek. I've written my name, so sorry, Dr. Abhishek. He's a pediatric neurologist in RNR. He's my friend, and he has given me some videos. So my primary objective, as I said in the survey, will be to let everyone be clear about the phenomenology of tics, so that you do not miss tics in your OPDs, and learning the how to differentiate it with other disorders and some basic premises of the management. I would address. Coming to some of the historical anecdotes, we all associate tics with Touré, Giladi Touré, but actually the first classical description of tick-like movements, closely resembling tick-like movements, were given by Yoon Yark Gaspard Ettard, who described the case of Marquis de Dampierre in 1825, detailing an involuntary movements and vocalizations. Subsequently, Giladi Touré, he published, I think there were 11 cases of the 11 subjects, and one of them was what was published by Gaspar Itard. So he bothered about not being charged against plagiarism. He also included the case, and then subsequently give this phenomena a name of Touré syndrome. And you can see in 1895 this was written, so long back. So the concept has still stayed on with us. Coming to very, very basic question, I would like to everyone to be very active, and I think you can unmute and share your views, or you can also type in the chat box. What is tics and what is Tourette? So I'll go. Tics are sudden, they are rapid, they are non-rhythmic. That is why I highlighted this. They do not come with a rhythm. So tremors come with a rhythm. Pulse, when we examine generally normal patient, you see pulse has a rhythm, but tics do not follow a rhythm. They are sudden, rapid, involuntary, recurrent motor and vocal movements, and or phonic productions, and they come in clusters. A child is sitting in front of you. The child might be able to mask, control, or suppress tics. When he goes out of the chamber in the OPD, goes into the waiting area, he'll actually throw these tics in bunches as if they were waiting to come out or explode. So that is why it doesn't follow a rhythm of a pulse. They are divided into two categories. We all know motor and vocal, and they are simple and complex. So what is simple, what is complex? I'll come to this later on. This I have made it with the help of AI, this diagram, but it is interesting. Let me just tell you with the help of a pointer. Yes. So we can see this is blue graph is tremor. So we can see it is following a rhythm. It is following a rhythm. See, this is following a rhythm. And we can see this is ticks. This is ticks, and this is doesn't follow a rhythm. So we can see the interdistance. Sorry, actually, I'm having a. Can I take a call? I'm so sorry. Hello. I'm so sorry.
मी एक छत्री माझ्यासोबत पिंक वाली घेऊ.
So I apologize. Sincere apologies. Yeah. So as I said, this is a very important slide, that tremors, they follow a rhythm. So you can see and that in the peak to peak distance is equal. But when we see ticks, you can see the peak to peak distance, inter-peak distance is unequal if you see in a very subtle way. So these are maybe 2.5 box. This is around 1.5 box. So they do not follow rhythm. And tremors are rhythmic oscillatory. Many a times, many ways we confuse between what is rhythm, what is tremor, and what is ticks. So, just to set the agenda of phenomenology, I would want to make things very clear that what is the difference between stereotypies, perseveration, and mannerisms. As we said, we want to be differentiating that one movement disorder from other kinds of movement phenomenologies. So, like when we talk about stereotypies, so
I'd
this
like
is
you
an
to tap
example.
3 times on the table.
University of Rochester video. So what we can see in this video, I think every one of you can type in the chat box. What we can see in the video. I'll play it again.
I'd like you to tap 3 times on the table.
I'm waiting for the responses. So this is, yes, perseveration. Perseveration means persistence of a motor activity beyond the point of relevance. So the patient is continuously doing one activity after a stimulus, but continues to carry the activity, motor or vocal, beyond the point of relevance. And we find it in frontal lobe syndromes. So this is perseveration. Mannerisms is idiosyncratic. Uh, any like film stars would do, any idiosyncratic modifications of normal postures or normal manner of speaking. So that you cannot explain. It is kind of an idiotic kind of a thing. But stereotype is, I'll come to this later on. So now coming back to the tics. So, if there is motor or vocal tics is less than 12 months, we call it provisional tic disorder. Before coming to what is motor and vocal tic, I'll come to this later on. If motor or vocal tic is more than 12 months of age, we call it chronic motor or vocal tic disorder. If there are more than one motor tics plus vocal tics for more than 12 months, we call it Tourette syndrome. But these onset should be less than 18 years of age. So I think the survey first question is like the motor plus vocal, more than 1 year, less than 18 years is Tourette syndrome. But if any of these categories are more than 18 years of age, we call it other specific tic disorders. Importantly, is we should not symptoms are not attributable to physiological effects of substances like stimulants. So stimulants can cause transient tics or any other medical condition like post-viral encephalitis. So post-viral encephalitis tics. So this should be excluded. Now, importantly, see in DSM-5, most of the places where we have used word disorder, we have included dysfunction there. Dysfunction. But here, when you see the criteria of DSM-5, whatever I have mentioned in the last slide, there is no mention of dysfunction. This is important. It has some treatment implications. We'll come to this later on. What is the prevalence of Tourette disorder? Anyone? Anyone? Any guesses? Any intellectual guess or wild guess? Hmm? Yes, I think we have one response. 0.1%. 1%. Yes, Dr. Bhageshri, you're right. So the prevalence is equivalent to the prevalence of psoriasis, the prevalence of schizophrenia. So this is important that the prevalence of Tourette is around 1%. But when you talk about any tics, it goes to 20-30% because tics may be pathological, may not be pathological. I think well answered. So it is the 1%. So now very important question, does all tic disorders are Tourette? Yes or no? Very simple. I just want to hit on to your understandings. Hmm? So does all tic disorders are Tourette? Yes, but all Tourette's are not tics. So all tic disorders are Tourette. So you have to understand that Tourette's are those tics which have only motor and vocal, motor plus vocal more than 1 year and before 18 years of age. So we cannot say that all tic disorders are Tourette, but yes, all Tourette disorders are tics. This we have to understand. So Tourette criteria is little narrow and tics disorder criteria is broader. Coming to motor tics. So motor tics are divided into simple and complex. Simple is only single muscle or localized group of muscles. Complex is more complex, either a complex action or a coordinated pattern of movement is present in. So this is an example of a video. You can see there is a shrugging of neck. There is a jerking of neck. There is a jerking of neck in different directions. Again, a jerk. You can see eyes blink. One more jerk. You can start typing what kind of text is this. You can start typing what the kind of text is this. Yes, I think Dr. Aarti has written complex tics. So you can see very simple eye blinks or simple tics. But when you can see that the neck and at times the shoulder moving together with a rotatory movement of the neck. So those are patterned movements. They can be termed as complex tics. This is a continuum series, which is, I'll just go to directly to the, sorry. I think why it is not playing. It is not playing. Wait. Yeah. Yes. So you can see it's an interesting video. A boy with Tourette syndrome demonstrating frequent blinking, alternating facial contractions.
This boy demonstrates frequent blinking, which is associated with alternating facial contractions, tongue protrusions, and mouth openings, typical of Tourette syndrome.
You can see multiple vocal, multiple motor, and video doesn't demonstrate the vocal component of it. And here you can see complex movements.
With Tourette syndrome demonstrates repetitive, complex movements produced by contractions of his shoulder and trunk muscles, preceded by an intense premonitory sensation of a chill.
Premonitory sensations can be
Do you have any warning before you have these tics?
Yes,
What do you feel?
sort of like a chill going up my back,
Okay.
and it's sort of like a cold chill, and starts getting worse.
And then once the movement that you have.
So here you can see it's easily, you can say that these are complex motor movements because they're more patterned and involving more than one muscle group or more than one muscle groups are involved here. And premonitory sensations can be an urge, can be an itch, can be a sensation, can be a chill. Chill is pretty rare, but I think you're fortunate enough to see this in this video. Another video.
This boy with
Also the same video. So coming to these are the three videos comprising of motor tics. The first one had clear, simple motor, maybe complex. Second one, again, simple motor. The third one was clearly showing complex motor tics. So vocal tics can be simple, where you will have various sounds and noises like grunts, barks, hoots, hollers, moans, groans, sniffs, and throat clearing. Complex one will have cluster of simple actions or more coordinated pattern of vocal movements. So these are actions in terms of vocalizations. So this is an interesting video.
This boy with Tourette syndrome demonstrates a dystonic extension of his neck associated with repetitive expiratory grunting sound. In addition, he demonstrates a holding or blocking tic, during which time he stops breathing and is completely motionless. With repetitive.
So you can see here very interesting video where when we what we call as a sustained contraction is dystonia. So if any patient is having this dystonia, and with dystonia you are having tics either vocal or motor, so we call it dystonic tics. Tics coming on the background of sustained muscle contraction. So a very good video to show what is dystonic tics. So where the child is in dystonic posture and having expiratory grunting. So vocalization, simple vocalizations in the background of dystonia. So dystonic vocal tics, number one. Number two, this is a very rare thing which is demonstrated in this video.
Expiratory grunting sound. In addition, he demonstrates a holding or.
So this is holding. So the pause, the silence. So tics may not always be vocalizing, moving. So any silence coming on the background of this chaos this is blocking tics, and which can be confused with any ictal phenomena. So again, something which we need to keep in our mind to a patient who is not responding to with anti-epileptics and having background issues unmissed. I think this is a very, very interesting video. So blocking tics, as I said, this is prolonged tensing of abdominal muscles in mobility or straining. Coming to complex ones.
This 17-year-old girl with severe Tourette syndrome exhibits complex motor tics and loud screaming phonic tics.
So you can see here things are, they have combined both the kind of tics in a very nice sense. Similar to last video was showing more of a dystonic tics with blocking tics. Here you can see coordinated movements of both the limbs, both the legs, they were extending when there was a motor component of tic, and loud expiratory grunts. So in context of simple vocal tics, they were loud, but the phenomena was still simple vocal. So this is interesting.
This boy with severe Tourette syndrome exhibits complex motor tics and loud phonic tics, including vocalizations.
We can see throwing obscenities, and again there are involuntary rapid. So these are coprolalias. So I think very difficult to observe. So we are lucky to have this video recorded. So coprolalias. So you might find this in a lot of histories where parents will tell you, my child, he's hyperactive and he'll suddenly throw a lot of expertise. And you might attribute to him learning from his environment, might be having coprolalia. So again, vocal alternations can also include pauses and hesitations in speech, word interjections, changes in tone pitch, and prolongation of words. Again, so it might we might think is stuttering can be a vocal alterations in terms of prolongation of words. So again, a kind of vocal tics. Now coming to, can motor tics cause vocal tics? I think I invite the response in the chat box. I think I have one response. Yes. I think Dr. Bhageshwari is very prompt. Anyone else to response? Yes, because motor, sudden thrust of abdomen, so can cause expiratory grunt. So motor tics or a contraction of muscles can cause those expulsion of air from respiratory system in expiratory grunt can be caused. So vocal tics can be secondary to motor tics also. Can tics cause injuries? Because seizures, we have come to know that seizures can cause injuries, myoclonus can cause injuries, or GTCS in terms of epilepsy can cause injuries. Whether tics can cause injuries? Yes or no? Dhruv is saying yes. Myelopathies, so tics, the rapid jerky extensions or stormy extensions of your spine can cause myelopathies. Ocular damage, they can be so strong and they can play with your eyes, or bodily injuries. So it can be equally, or if not less catastrophic than the seizures. Number one. Number two, premonitory sensations. Urge can be stronger than, and maybe urge to give to obsessions or yield to obsessions. So this is also important. Now coming to various characteristics of tics. Tics generally will have some precipitating factors like change of temperature or any stress or any anxiety. They have waxing waning pattern. So maybe the child goes to Dr. Kulkarni and he prescribes a medication, and then I think after a couple of days the tics goes off, and then the family is very very happy. Sir is also very happy, but maybe it is the waning pattern which has spontaneously come up. So we might get tricked into it, and maybe couple of weeks similar medications returns back. So that can be pretty frustrating. Importantly, in children, premonitory urge or sensation is present only one third. Then child can briefly suppress them, as I discussed before. In front of you, you might not be able to see it. Reduction, when the child is distracted, it might reduce a bit. It is more common in males than females. So the ratio is 4:1. Typical age is 4 to 8 years of age. Importantly, motor will precede vocal. That is why in Tourette syndrome, they have given more than one motor plus one vocal. So motor is more, we need to be, it is given more importance, I would say. Now coming to comorbidities, which are the two comorbidities which we need to, so if we take C tics in a patient, or we see persistent tics for more than 12 months, we need to screen for at least two comorbidities. Very, very importantly, do not get carried away by the whole lot of spectrum, that is ADHD and OCD. We need to look into the hyperactivity. Child might not be hyperactive in your clinic, might not have the obsessions because child is too small to report it, may have some rituals or just right phenomena in terms of OCD. So we need to probe into it. Now this is important. Monitoring is important. Nowadays, I'm going to the next section. Nowadays, what is important is, because of social media, we can ask parents to send us a lot of videos in the WhatsApp group, recording the phenomenology at home. Why? Because this case is very interesting. You can see the videos recorded from home. This uh, adolescent was not given us any clue. It was worked up by Dr. Kiran. I think she's in the audience. So she can see, when we could zoom it, he had these facial grimacings and frequent blinkings on perioral muscles. So these are tics. So things would, and he came to us with hyperactivity and behavioral issue. So on the background of tics, we managed him, he settled down. So monitoring is very, very important. So nowadays, in context of social media, it is not very difficult. What happens to tics during sleep? I think I need responses in the chat box. What happens to tics during sleep? Do they increase? Do they subside? Yes, I think I do not have the name iPad. Someone the name of iPad he replied yes. Tics would suppress. Most of the movement disorders will suppress during sleep, except couple of them like non-kinesogenic dyskinesias or palatal myoclonus. So they will not be suppressed during sleep. What happens to the tics when a child comes to you with Tourette syndrome and maybe 5 years of age? Parents are very, very disturbed by it and they are very anxious. So, what is the course of tics? So, tics course is one third, one third, one third. Easy. One third will persist, one third will remit, and one third will worsen. So, there are few indications that who will go into what, but there is no broad consensus to it. So this is important that maybe the child with comorbidities, the child with other subtle neurological issues, neurodevelopmental issues, the course might worsen. Otherwise, one third of them they might remit. So at times, good psychoeducation will solve the issue. In tic disorder diagnosis, there is no definitive diagnostic laboratory test. It is again test. It is diagnosed by your clinical discretion, which stands true for most of the psychiatric disorders per se. Now, this is important. This is one of our case which we have sent for publication also, and one of our residents had presented in one of the case conferences in the conference in one of the conferences in case conference. So I'll just play the video. She's an 18-year-old female who came to us with these repetitive movements and severe intellectual disability. She was completely dependent on the family for basic living. And by till 12 years of age, she was doing absolutely fine, had a fever, and then subsequently had massive regression and came with these clapping movements. So, what are these clapping movements? Sorry. What are these clapping movements? Or what is this movement phenomenology? And she would completely repeatedly do this throughout. So anyone can unmute or type in the chat box. I'll play this again. So this is the movement. So this is, she would repeatedly do these movements without any stimuli or any initiation on the part of the examiner. This is completely non-goal directed and spontaneous. So these are stereotyping movements. These are stereotyping movements. So we can call it stereotyping movements in terms of movement phenomenology. We requested for an MRI. The family was very poor, and we could very, very surprisingly see here that the whole, this is not a ventricle. This the whole anterior posterior, this whole white matter demyelination happened. So there was extensive demyelination of the brain. You can see with rings shape appearance in the ventricles. And if you go to the other top cut section, when we are doing horizontal sections, so this is leukoencephalopathy. So this probably because of the fever or any XYZ cause, she went into leukoencephalopathy. We thought we'll go for whole exome because she couldn't afford, so we couldn't go for genetic testing. So we couldn't exactly do a phenotype what this case belongs to. What is this? So I'll be showing you various variations of various movements. What is this movement? If anyone can type in the chat box, any responses? This is midline stereotype. We get it in Rett syndrome. Midline ringing movements. I think the previous question answer is more valid for this video. This is important. This is interesting. So we can see, if you can revisit the video again, you can see after 4 or 5, third, fourth or fifth angle of mouth. So when you could see this jerk in the angle of mouth. So when we see, we have taken a screenshot at this phase, there's a jerk in the angle of mouth, kind of a bridling movement. So we can see this is ictal pouting. And was mentioned in one of the journals. We did an EEG, we could find an abnormal paroxysm. MRI was normal, 3 Tesla. We thought that there is something needs to be there. Maybe with good resolution of MRI, we might find something. But the child is responded to antiepileptics. This is interesting. Sorry. 10-year-old girl who came with these abrupt onset vocalizations. And parents were very disturbed by this. So what is the impression? Though I flashed my impression, but still for the discussion's sake, any ideas? I'll play it again. And this was coming in bunches of clusters. So you can see there is grunting, expiratory grunts in terms of vocalizations. And they were pretty abrupt in onset at 9 years of age. So when you see the characteristics of tics, they are more common in males. The age is 4 to 8. So the here it is in female, age is surpassing that 8 years age criteria, where the age of onset happens. Secondly, when you see motor will precede vocal. So here the predominant presentation is vocal and associated with the movements of shoulders and chest. So my point here is that all these things are indicative of, and when we probed, there was some exam-related stress, education-related stress. So this is known as functional tic-like behavior disorders. And in Japanese, in Asian countries, these kind of behaviors had an uprise after TikTok was launched. So maybe they correlate with some TikTok videos or the allied phenomena. I don't know how to explain it, but these are known as functional tic-like behaviors, where we need to, these are not tic disorders. So we need to see whether they are fitting into those patterns or not. So again, very interesting video. I'll skip this because I think this will become, yes, this is interesting. So what is this? So you can see there is some contraction. What you all can see? You can just type in the chat box. This is something very, I need to see how observant everyone is. What all you can see in this video?
आपका नाम क्या बेटा? और कौन सी क्लास में
eye
पढ़ते हो?
blink, right? There is eye blink. There is some blink in the
दोस्त
left
हैं
angle
आपके?
of mouth.
कौन-कौन है friends आपके?
Then, and if you can see, there is a contraction here. You can see here. There is arm. This is biceps is getting contracted without him volunteering doing it. This is very interesting. Along with some eye blinks and some angle of mouth. Okay. So what is this? Okay, Caesars. So this contraction is what? So interestingly, see when we actually zoomed it, so you can see these muscle contractions. So very, very interesting. You can see here similar contractions in, this is trapezius or sternocleidomastoid, sorry, or trapezius. So these are exquisite motor control phenomena, and these are extension of tics only. So tics, when the child is suffering from tic, they will have exquisite motor control, exceptional motor control over those muscles which normal people will not be able to control their contractions. They will be able to control their contractions. So this is very, very interesting. So if you look into this video, and if I basically, there are other contractions also, other muscle groups also they have shown. Anyways, so what is this? The video is not being playing. Some issue with this video. I think I'll then skip this video because I'm not able to. It's not running. Some issue with this video. Yes.
Keep your hand
See
down.
this? What is this phenomena? The parents are very, very disturbed. They send this video. Ki is there any issue with her?
Keep your hand down.
Please. What is this video? Anyone? Any responses? So interestingly, this is sighing dyspnea. And this is functional. You just have to reassure the parents. You have to just tell them to ignore this. Sighing dyspnea. This is interesting. This I've got this video from a movement disorder group, which I'm part of. So what is happening to this child? Any responses? I think then becomes more interactive, then becomes more interesting. I just want to know what do you people think of, whether it is right or wrong, that is immaterial. So what is this? What is happening? He is extending, repeated extension of the spine is there, repeatedly extension of this the cervical region, and doesn't carry any rhythm as such. So this is whiplash cervical tics, whiplash tics we call it. So again, interesting. This is one case which we had published. I was framing this presentation for pediatric department because they wanted me to present on the tics, and then I was just reading about tics, so I came across genital tics. Fortunately, or maybe unfortunately, I came across a child sent by pediatrics department. That child would vigorously rub the genitalia, and it was done in absence of others. But most of the child will go into the room and will rub the genitalia. We requested for the videos. They did not provide us the videos or consent for it, citing the obvious reasons. And then when we uh, treated the child for in lines of tics, the child actually improved significantly. So there are no genital rubbing behavior. So rare. So we published this in Journal of Psychosexual Health in terms of genital tics. So again, the tics can have a broad spectrum of phenomena. What is happening to this patient? This is our patient. We have submitted this publication, a video-based publication in one of the. So you can see the scalp muscles are moving, right? And we see a lot of patients, we see this kind of an scalp movement, and we wonder what is happening. Again, part of tics explained in terms of, again, exceptional motor control. But here, patient was exposed to high dose antipsychotics, and after the exposure to antipsychotics, after months of exposure, he developed these scalp movements, and the family was pretty worried. So these we conceptualize on the lines of tardive tics. So what is this? This is stereotypic movements. The child is having autism, and he'll actually continuously do this movement day in, day out. Again, in context of movement disorder, this is persistent contraction of the neck for 30 to 40 seconds, and then he'll, with some suggestions, he'll come back to the normal. So this is psychogenic non-epileptic seizure. Coming to the various things which we had said about stereotypies, perseveration, mannerisms, then various kinds of tic videos, simple, complex, motor vocal, and then coming to videos for stereotypies, midline stereotypies, and then various differentials of exquisite motor control, and then the PNES, the stereotyping videos. I mixed it because I didn't want to and want everyone to keep on guessing. So to a very basic phenomenological issue, we call every child who is throwing some behavior, we might call that X behavior as agitation, Y behavior as restlessness, and and so-called behavior as hyperactivity, without exactly knowing what we actually mean by it. That is why I thought that I'll keep it this in this presentation, and which is very, very important for postgraduates, because basic things should be the basics should be very, very clear. This is again University of Rochester. This is a video available freely available on YouTube for public use. So this is there is a diffuse increase in movements, and we call it restlessness with increased mental tension. This is a little similar video on similar lines. We can see again the movements are increased, and he appears to be distressed facially. So this is restlessness, where state of increased muscle tension will diffuse increase in body movements, such as fidgeting. It is important. Please remember this. Then what is agitation? How will differentiate with agitation? You can see this. The amplitude of movements is very, very much higher than plain restlessness. And obviously, a lot of distress. So if you see the big fish is agitation, the small fish is restlessness. Agitation is patient will be constantly walking, pacing, wringing hands, moaning, uttering words of mental distress, and pretty aroused in arousal state. So this is agitation. Coming to hyperactivity. So when we call someone having a mania patient might have goal-directed hyperactivity, might go into agitation at different times, or might be restless going into agitation, and might become when we treat him with some medications, the agitation might settle into hyperactivity. So you can find all these three things in one patient, but please, you have to know exactly what behavior is termed what. So hyperactivity is generalized overactivity plus increase in physical energy. It is more purposeful, but lack of inattention. So an ADHD child, when the child is allowed to run free, takes utilizing the open space, the child you see the genuine hyperactivity in the child. Coming to the pharmacological part, the part of it, the aspects of it, drugs causing tics, the cocaine, neuroleptics like tardive tics, lamotrigine. I was very surprised. Very famous neurological tics has given lamotrigine and stimulants. So I think we need to be careful about lamotrigine now. Coming to treatment, importantly, there is no cure. This is very important. A lot of us, because of parental anxiety, we start treating, simple motor tics, simple eye blinks, simple neck shrugging. We should avoid it. If it is dysfunctional, then only carry it. Dysfunctional of the child in terms of the child's school, the studies, or any other dysfunction in domain. But we should not treat because it has waxing meaning. The child might the things might improve. So what is the point? And if it is mild, reassurance, good psychoeducation, habit reversal training. FDA has approved 3 agents for tics: haloperidol, aripiprazole, and pimozide. Surprisingly, risperidone is not approved by FDA for tics. This is the treatment chart. Important. This is important treatment chart because just sorry. So we first have to attempt behavioral therapy in India because lack of people trained in behavioral therapy. We directly jump to pharmacotherapy. Tier 1 medications now, they are those who have lesser side effects. So that is why they have put maybe lesser efficacy but lesser side effects. Guanfacine is not available in India. Clonidine is available. Topiramate is available. Clonazepam and baclofen. Tier 2 are effective, but because they have more side effects, they are kept in Tier 2. VMAT inhibitors, tetrabenazine, I think it is not seen anyone who has tolerated tetrabenazine, any child. And forget about child, any adult also. So I think Indian population is very, very poorly tolerant for tetrabenazine. Why? Because one of the metabolites of tetrabenazine can cause Parkinson's. So they generally come with extrapyramidal side effects also. Deutetrabenazine, valbenazine not available in India. Other agents like cannabinoids, CBD, we are yet to generate evidence. Botulinum toxin for motor tics. It is, yes, it is important. And as I've highlighted, deep brain stimulation for bothersome motor variety of tics. It is, I still remember a child we treated, he was maintaining well on in Tourette syndrome, he was doing well on risperidone, became symptomatic, we changed him from risperidone to aripiprazole, then to haloperidol, then we gave him topiramate, he became transiently better, but he subsequently started worsening. We sent him to an neurologist, a reputed neurologist in North India, immediately responded that he needs DBS. Otherwise, there are no other treatment options. So it is reserved for refractory cases whom various drug trials have been conducted. A few words about clonidine because it is one of my favorite agents. You have to go into 25 microgram increments. So start with night 25 microgram, go every 15 days, keep on increasing it, and till you can the child can tolerate it. Mosley says 3 to 5 microgram per kg per day. So child is around 50 kgs, for example, maybe 30 kgs. So maybe 100 micrograms. You can go for 30 kgs child. So you can actually divide it into 50 morning, evening, but start with 25, go till 100 in that context. This combination is the clonidine is pretty healthy when you have Tourette with ADHD. So as per a very reputed source, neurology, this is from Neurology Journal. So they say that it has, and they have given some practice guidelines, statements. So they say that this is important. So I just wind up with this continuum article, which is very, very useful for tics, learning tics and Tourette syndrome. Many things which I have shared here in terms of movement descriptions and movement phenomenology, how to differentiate with other disorders, it is given here. And these are the practice guidelines I was talking about. With this, I would like to sign off with my alma mater, where I did my post graduation from Central Institute of Psychiatry, Ranchi. Thank you. Thank you.
Thank you, Dr. Shobit, sir. And it was one of the comprehensive presentation about the phenomenology and symptomatology of the tics and Tourette's. You nicely summed up, the identification, the difference between tics and various types of tics, complex, motor, and vocal, and simple. So now I open this forum for questions. If any questions can be asked in the chat. Sir, I have one question because you were sick. Now, as a psychiatrist, where do we come into picture with why is it important for us to know tics?
Sir, it is one of the first of all, it is highly comorbid with neurodevelopmental disorders like ADHD, OCD, anxiety, and the treatment aspects also when you see, sir, the ginkgo biloba or the clonidine or maybe the risperidone, aripiprazole. So the treatment basket is reflecting, and it is a clinical diagnosis. And when we talk about its interface with neurological from organic point of view, then only we should go into the other side of the corner. Otherwise, it is, I would say, it should be managed by comprehensively by the mental health professionals.
We have one question in the chat box. Role of habit reversal, how much significant, sir? From Dr. Bageshwari.
Yes, in mild in mild varieties, so habit reversal might be useful. Uh, I cannot generate data here for you, but let me give you my experience. I learned habit reversal therapy. I was very interested in tics. Problem is the most of the children are 4 years, 5 years, and they have hyperactivity very commonly, as I shared, 50 to 60%, and they'll not follow this. When you try to so what is habit reversal therapy? Is when you actually ask them to develop an exact counter habit to whatever tick is letting them to do. So maybe some this shoulder is shrugging, so you have to ask them to develop an habit of shrugging this shoulder in order to counter this shrugging shoulder. Or maybe have a some band, a rubber band, and whenever you're having the premonitory urge, you have to strike the rubber band strongly in order to counter that urge. But it is very difficult to let them follow HRT. So that is why outcomes of HRT were very frustrating. So practically speaking, then we are left with psychoeducation. If it is a milder variety, let them ignore it. If it is dysfunctional, treating them with medications.
There's one more question, sir, from Dr. Asta. Can you please elaborate on tardive tics?
Yes. So, Dr. Astha, so tardive tics is when we talk about tardive movement. So, they happen after a few months of intake of your dopamine blocker, antagonists. So, whether they are being continued or they are withdrawn. So, so we call it dyskinesias, we call it tremors, and then we also have tics. So, what if the motor phenomena is resembling tics, and it is correlated with your temporal correlation is with your antipsychotics, and going for a period of time, then we call it tardive tics.
And there's one more question, sir, from iPad. The question is, can motor tics appear only during anxiety?
Yes, you're right. So in physiological conditions, you see normally in normal population, you might find that when we are very anxious, we do all sorts of funny things. So my the shoulder shaking will come up, the neck idiosyncratic neck jerkings will come up when we are in anxiety. So these are embedded phenomena when they come up. We then do not call it disorders because the criteria needs 1 year and before 18 years, and it should not be explained by any other physiological state. So and these are pretty common. These are pretty common. So it is wrong to treat these kind of phenomena. Then you have to address the anxiety, I would say.
Dr. Aarti Susilan asks, sir, since tic disorders have moved from neurodevelopmental disorders to diseases of the nervous system in ICD 11, so we as psychiatrists should treat only primary tic disorders.
Mimi, see, if even if they have moved a section from neurodevelopmental disorders to disease of nervous system, so I think that doesn't deter us from treating these primary tick disorders. Secondary tick disorders also, I'm telling you, like in context of Huntington's, for example. So Huntington's chorea, or at times it presents with tics. What is the treatment? What will prescribe is haloperidol, and we are able to dose titrate it better and monitor it for the side effects better. So if the phenotype is clear, so neurologist's role very importantly is to define the phenotype. As I showed that case of stereotyping movements. So that patient came to us, we admitted the patient, we clearly framed the phenotype. We took one neurologist from our team in order to who helped us in deciding the phenotype. Then it is clear, okay, we are dealing with the movement disorders, which is part of one cluster of an abnormal picture. So till then you need support, but once it is clear, then I think it's a teamwork. So it is not in category actually. So right away from picking a movement, if it is movement is of primary tick disorder, secondary tick, some other disorders, we need help. And once we are clear, then we manage it as a team, I would say.
In your clinical experience, how many patients of OCD had tics in their childhood, or on continuum basis?
So a lot actually at times, they frequently come with just right phenomena. They will be shifting things. They will be putting things in their place. And interestingly, we find just right phenomena in ticks also. So, and the combination is very, and when we treat OCD in children, at times we miss
This
the ticks part of it.
and does it affect the prognosis, like having tics and having OCD? Where do we stand when they're comorbid or when they're there together?
See, any comorbidity, it has to affect the prognosis in psychiatry, except schizoaffective disorders. So that is what I actually tell everyone that. So if there are two or three disorders, it has to affect. But it also makes our clinical decision making a little easy, because if there is a tick with OCD, we have to instill second generation antipsychotic or maybe first generation antipsychotic little early, so that we can take care of the tics and also take care of the OC phenomena. So in that sense, like ADHD and tics, so we can start clonidine early. So my point is that can help us in some decision making.
Yeah. Thank you, sir. I see no more questions. Is there any other? I'll just go through. Sir. No more questions. One question I missed, I think, sir. What about akathisia complex partial seizures?
So I think I'm not very clear
What exactly the question?
Question is. So if you're saying ki complex partial seizures versus akathisia, phenomenologically difference. So akathisia will be more longer, more persistent, subjective and objective restlessness will be there, temporal correlation with any medication will be there. Complex partial seizures will be very brief, stereotypic presentations where you'll have altered awareness. So I think that can make our job little easy.
So thank you very much, Dr. Shobit sir, and Rashman sir. I'll hand over the session to you.
Oh, thank you. Thank you. Brilliant. Absolutely brilliant. I'm glad we had this because I think movement disorders and tics in particular is something that we see so much of comorbidity of, but it is seldom ever focused on adequately and never ever talked about even more so. So thank you, Dr. Shobit, for bringing to fore this very, very subtle but a very, very common phenomenology that we see in multiple psychiatric illnesses as well as a neuropsychiatric overlay. So we are grateful to you for having had this talk with us and made the time to be with us on this platform. And of course, Dr. Pawan, thank you very much for making the time because your expert comments and your feedback also add a lot of value to it. So thank you, all of you, and thank you for being with us. And Chetan, I hand it over back to you to give us a vote of thanks.
So, good evening once again. On behalf of the organizing team, I extend my heartfelt gratitude to all the speaker, the delegates, those who have attended today's session, the participants, and the uh, uh, the chairperson for on making this event a successful one. So we from the Department of Psychiatry, D.Y. Patil Medical College, would like to especially thank our esteemed speaker for the day today, Dr. Shobit Garg, sir, for sharing valuable inputs and simplifying the topic, an interactive session, and a very practice-oriented session. Thank you, sir, for simplifying this topic. I would like to sincerely thank Dr. Pawan Kumar Kulkarni, sir, for graciously chairing the session and moderating the session, taking up the questions of the participants really well. Sincerely thank again all the delegates, all the participants. I would like to see more participation in the upcoming lectures. Thank you, everyone, and have a great evening ahead. Thank you.
Thank you, Dr. Chetan.
Thank you, sir.
Thank
Dr. Pawan, sir.
Shobit sir, thank you very much.
Okay.
We'll meet soon.
Yeah, sir. We'll meet soon in Bangalore, sir.
Yes.
Thank you.
Right.
Thank you. Oh, sir.
Thank you all.
Right. Take care.
Thank you, Dr. Ashwin, sir. Thank you once again.